So thank you for that introduction. I'm truly honored to be here. I'll say if there's one lesson we've learned from COVID-19, it's that the public health workforce that we have right now consists of some of the most committed, hardworking, selfless, and essential members of the framework of our society. And I do some work in belonging strategy. And one of the definitions of belonging is being in the right and suitable place and knowing it. And for those of you who are in the field of public health, entering the field of public health, I want you to know that you're in the right and suitable place. You belong here. You belong in the field of public health, and honestly, never before in recent history have your efforts been more needed, more relevant, more important. In my role as the director of the National Coordinating Center for Public Health Training within NPHI, I'm asked often, what's my vision for the future of public health? And as I see it, there are at least 4 core areas of progress that really need to be embedded in our strategies as we think about the future workforce. And the first, as has been mentioned, is centering the public health workforce, centering them, focusing on our people, the core of public health infrastructure. The past 2 years has taught us as a nation that we couldn't have done much of anything without the public health workforce. Those who have put their personal lives on hold, the stand-up testing centers, staff call centers, serve as contact tracers, the list goes on. That's the core of public health. So as we do this work to build back better, we have to invest not only in the professional development and education that we're talking about today, but in the mental health of our workforce. We have to ensure that we're treating the public health workforce as whole people, not just cogs in this machine that we call public health. And I know you've seen it with the personal stress and the uncertainty caused by living in this pandemic and the stress of the work that we do in public health. It's not surprising that public health workers are experiencing symptoms of depression and anxiety and PTSD and suicidal ideation. There's been a relatively recent MMWR article that talked about this, and it noted that over half of the surveyed public health workers across state, tribal, local, and territorial health departments, they reported symptoms of at least one mental health condition in the previous 2 weeks. So to address this idea of looking at our workforce has to include developing workplaces that promote wellness, cultivate cultures of belonging, and destigmatize requests for mental health assistance. Quality employee assistance programs, efforts to raise awareness of symptoms of mental health conditions, opportunities to learn more about emotional intelligence and coping skills are just a few of the examples of the ways that we can move this forward and really center the health of the public health workforce. Second, it is absolutely time to embed principles of racial health equity across all elements of public health policy and practice. Will Jawando, who's a city council member in Montgomery County, Maryland, he said, whether it's police-involved killings or disparate health outcomes where Black American patients can't get treatment because they're not seen as being sick, or financial redlining in certain zip codes, or food deserts, or people of color getting hit by cars more often because their communities are not walkable, it's all ultimately due to racism. Now, yes, high rates of poverty and employment, poor housing, toxic environmental exposure, less access to quality medical care, all of the social determinants of health certainly contribute significantly to these health disparities. But I want to remind you that all of our systems are staffed by human beings, individuals who are subject to the various social constructs and programming and beliefs that the rest of us are. And what this means is that racism, bias, and discrimination are as much a part of public health practitioners of our workforce as they are a part of the general population. As I often say, if you are breathing, you are biased. But some of us, human beings, are in positions of authority, and we don't even really know it. Whether consciously or unconsciously, we have the power to exert influence over another individual's experiences and health outcomes in ways that can be profound, long-lasting, and generational. So as leaders, and we're looking at this next generation of public health leaders, we've got to be courageous enough to look for bias within our organizations, both implicit and explicit, and weed out the ways that racism is operationalized in the data we collect in public health, the policies we influence, enact, and enforce, whose voice is given credence, our community presence and community partnerships, and how we manage and distribute resources, and in our hiring practices. I'm not saying that this will be easy, but we can't afford to wait any longer. And one of the ways that NPHI and the National Coordinating Center for Public Health Training are working to move this forward is working with the 10 HRSA-funded regional public health training centers to create a racial justice competency model. It's currently under development, and more will follow as we move through the phases of wrapping that up. Third, the spotlight on racial health equity also opens the door to a needed conversation about gender parity in public health and population health leadership. The reality is, no matter where you go in this world, the default frontline health worker is a woman. We know that women hold 70% of the jobs in our workforce, but only 25 to 30% of leadership roles. Public health is served by women, but led by men. We see disparities in scholarly publications and in citations. Like most professions, we see disparities in income. Women in public health earn 10 cents less on the dollar than men in the profession. And women in public health are 36% less likely than men to earn at least $95,000 a year. And when it comes to women of color, the wage gap is even more severe. For women, this inequity within our field is harmful to our health, it's harmful to our pockets, and it negatively impacts our sense of purpose and belonging. So while we're doing this work around racism as a public health issue, we should also be considering gender equity within the field. Gender equity is a public health issue, and one that we have an opportunity to address head on. The evidence base is there. We know that health systems function better when the women who manage them have an equal say in their design and delivery. We know that positioning nurses, for example, can lead to better health service delivery, better health outcomes, retention, and greater innovation. Women in health leadership expand the agenda. And this is an important issue for us to focus on and for the next generation of public health leaders to really lead in. And we also need to work collectively to do the work to repair public health's PR problem. And I see this as a two-part problem. First, related to mistrust, but also related to political reasons and our history of racism. But also ultimately, because we're not necessarily trained on how to be skilled communicators in public health. We need to get skilled in risk communication, and not just leaders, but across the public health workforce, because the reality is people that were from janitorial service people to leaders in the field, everyone that worked in public health was being asked about COVID and was in a position to provide messaging. So we need to spread that training broadly and widely and learn from each other's successes and mistakes. At NPHI, we are poised to collaborate with our more than 40 member institutes and the 10 regional public health training centers to serve as conduits to hire, train, and retain the next generation of the public health workforce. We're excited about piloting new curated training paths and certificate programs through our Public Health Learning Navigator. And I think it's a good time to point out here that we are seeing a growth in joint degree programs. As someone who's earned a JD NPH, I have found that having both degrees has given me an opportunity to move farther and faster and create multiple career opportunities and options that I've been able to pursue throughout my career. And these options create interesting career opportunities that ground people in the field and help with retention. So as I close, I want to mention that in your resources, there should be a link to a report that we created in partnership with the Kresge County Foundation. That's really an environmental scan focused on looking at the public health infrastructure. And it really creates an action agenda for public health for at least the next decade, covering topics including laboratories, public health law, and the public health workforce. Key findings from this report related to the workforce that I just want to point out really quickly to you. So the first is as JP touched on, there is a severe and consistent shortage of public health workers. And we are still looking at those numbers as it relates to COVID, but we can anticipate that it has been impacted by COVID. Number two, community health workers and other type of healthcare workers are underutilized sources of medical care for vulnerable populations, disadvantaged populations, who are not properly integrated into the healthcare system, which limits their effectiveness in improving healthcare outcomes on the community level. So we need to better integrate community health workers. We need to focus on teaching public health in middle and high school, because we know that this can expose students to public health early and increase the chances that a career in public health is contemplated really understood and ultimately adopted. Another important point to point out is health departments, I believe, really do want to provide training and education to their workforce. They've made efforts to provide such training programs for their staff, but there is a lack of funding. And there's a lack of coverage that we've heard about for staff members to attend this training during work hours, which means many people who want to advance their fields in public health have to do it during the evening hours. And that's difficult. And we need to make some changes in our field to make it so that this is happening during the work hours and on the job. Community colleges are an often overlooked fertile ground to influence a motivated, racially and ethnically diverse group of students to pursue public health. And another important thing to point out are practicums, mentorships, and internship opportunities. I know throughout my career, over 20 years, I have found people who weren't sure what they wanted to do with their careers or with their law degrees, and introduced the field of public health to them and let them see that there is a space for them. There's a space for just about every single discipline in public health, that public health is truly an interdisciplinary field, and providing that support that leads to a sense of belonging for folks as well. So key takeaways, as folks are executing training plans, I want you to think about the competencies that are often dismissed, things that are related to anti-bias, anti-racism, emotional intelligence. Being able to apply public health and racial equity principles within and outside our organization is critical to public health practice in the 21st century. Making professional development a priority shows staff, through funding and through time, shows staff that their agencies want them to stay and continue to grow throughout their tenure. And all of this reinforces a sense of belonging in the. And with that, I'll close, and hopefully there'll be some questions that I can respond to when we get to the Q&A. Thank you.
Thank you, Dr. Ransom. And that's a nice reminder for people to include in there. Go ahead and put any questions that you have in the chat for our Q&A portion. But thank you so much.